In this module, we'll be seeing the physical signs of lung fibrosis. This is an X-ray of right upper lobe fibrosis. Let me briefly tell what is actually seen in the X-ray, and what I will do is that I will correlate the findings in the X-ray with possible finding you may get in your physical examination. So that's how we will be doing. You can see that the right lung appears to be smaller than the left lung. You can see that the right lung appears to be total volume, if you look at it, appears to be less compared to the left lung, which occupies a larger space, as it is very obvious in the image. Now when you see inside, you can see that in the right upper zone and mid zone up to the fourth rib, you are able to see that there is a near homogeneous opacity. I won't call it as a homogeneous opacity, but it is very close to a homogeneous opacity. You are able to see up to this level. Okay, so this level appears to be having a near homogeneous opacity. And if you very carefully see, the trachea is curved. So trachea is literally pulled to the right upper part of the lung. It is just pulled to the right side. So this is a typical X-ray you will get in right upper lobe fibrosis. So we are going to see in this right upper lobe fibrosis what are all the possible examination finding we will get in during the clinical examination, so that you can understand the signs of fibrosis. Here I will be touching on what is called a replacement fibrosis, which occurs commonly after tuberculosis. Another one is interstitial fibrosis, which we will be taking at a later point of time. So this is the entire parenchyma gets fibrosed commonly after tuberculosis, where severe caseation actually occurs, and that leads on to fibrosis. What happens in the inspection? So bony environment of the lung, the shape of the chest may be overall normal. So shape of the chest may be overall normal, but the symmetry may be asymmetrical. Okay, it may be asymmetrical. Now what happens in our case? It is right upper lobe fibrosis. So what will happen? This AP diameter may be little shorter. So what will happen? There will be slight kind of an asymmetry on the right side, making an asymmetry in the anterior part of the chest. So sternal abnormality, generally it will not be there. So sternal abnormality is not expected due to fibrosis, or basically, as I told you, are looking into a sternal abnormality primarily if it is there before you look at the trachea. But there are certain conditions that the lung condition itself can cause abnormality in the bony environment. So that doesn't happen as far as fibrosis is concerned. But fibrosis can lead on to a scoliosis. So we call it as a secondary scoliosis. So what will happen? You have the convexity, isn't it? So what will happen? The convexity of the scoliosis, this is the convexity. So that may be on the side of the lesion. So it is a secondary scoliosis. So apart from that, you need to just look at sternal abnormality and spinal abnormality before you look at the trachea. So here in the examination of inspection, you may have an asymmetry of the chest and you may have a secondary scoliosis. Now in right upper lobe fibrosis, you expect a trachea to be deviated to the right side. Already we discussed this. That is the deviation of the trachea to the one side, right or left. It causes prominence of the sternomastoid clavicular head. This is the clavicular head which becomes prominent. It may be present. We cannot tell that it will be present. So on inspection, if the fibrosis is quite significant, you may have trial sign which is abnormal. Now in right upper lobe fibrosis, the apical impulse is usually undisplaced. right upper lobe fibrosis, it is undisplaced. But if it is left lung fibrosis, it may lead on to two things. Sometimes it may be undisplaced, or the apical impulse may be shifted upward by one space, or it may be shifted laterally, upward and laterally. So apical impulse involvement depends on which side is the fibrosis and the severity of the fibrosis. Sometimes when the entire lung is fibrosed, when the entire lung is fibrosed and it is shrunken very much, then the heart may get shifted to the right side. It's called dextroversion, and the apical impulse may move more medially. Okay, so that depends on the severity of the fibrosis under question. So volume status is likely to be affected in fibrosis, that we know. So if the fibrosis is very severe, for example, if the right lung fibrosis is very severe, you may have the drooping of the shoulder. So drooping of the shoulder may be present. And usually in fibrosis, what we see in practice is there is supraclavicular region hollowing. Because the upper lobe is commonly fibrosed after tuberculosis, you may have a supraclavicular hollowing secondary to fibrosis. In more severe fibrosis, infraclavicular region also may be hollow. Winging is rare. Winging due to fibrosis is a rare phenomenon. For that matter, any primary lung pathology causing winging is rare. I think I will touch this point earlier also when we discussed the inspectory findings, generally in respiratory system. Intercostal space may get crowded, especially only when the entire lung is fibrosed. So intercostal space, you expect a crowding which occurs only in the entire lung is fibrosed. And clinically I am telling. Radiologically, even in the X-ray, you would have noticed that we are able to appreciate a narrowing of the intercostal space. So the most common thing you will expect is the supraclavicular region hollowing is very characteristically seen in fibrosis. So chest expansion. So you can see that in this video, see only the left side will be moving. Right thing will not move at all. If you see very carefully, the shoulder will not move. The scapula will not move away from the spinous process. This is a spine. So what you need to look at is how much does the scapula move upward and outward on the left side, how much it moves in the right side. So you can see that on the right side the movement will be almost absent. See it very carefully. So this patient movement is affected because patient has a right lung fibrosis, probably a entire right lung fibrosis, because the movement is very significantly affected. Now the next one is the chest wall signs. So the scars, erythema, dilated veins, sinuses, you won't get that. Let me just tell you what are all the situations where you get this. Basically you look for scars only to have a clue about previous intercostal drain placement. So that is more relevant in relapse of tuberculosis. Erythema, we look at the chest wall mainly when we think about the possibility of an pus in the pleural space, that is empyema is a condition where we suspect. Dilated veins of the chest we expect in bronchogenic carcinoma as a complication of the venous obstruction it causes. And sinuses, I told you, it can happen in tuberculosis, it can happen in empyema, it can happen in also fungus. So empyema etiology can be tuberculosis, it can be fungal infections, or it can be actinomyces also. So those are the situations where you will get these changes in the chest wall, which it does not happen in fibrosis because it's actually a sequelae which actually leads on to fibrosis. Now, tactile vocal fremitus, I think I would have touched upon it in the initial examination also. It just tells about how the sound is filtered, which is produced at the vocal cord. So when there is lack of filtration of the frequencies, because I told you that the lower frequency sounds are actually filtered off by the normal lung parenchyma. So the tactile vocal fremitus and also vocal resonance is variable in lung fibrosis. So what happens in early fibrosis, tactile vocal fremitus and vocal resonance may be increased. At the advanced fibrosis where the lung is very much shrunken, it may be decreased. Again, the tactile vocal fremitus and vocal resonance may be different between the upper and the lower part. For example, in right lung fibrosis, in the upper part, since the trachea is deviated to the right side, so trachea will be pulled towards the right. So here it may be increased, tactile vocal fremitus and vocal resonance, and in the lower part it may be decreased. So the better to remember it as variable. Depends on the stage of the fibrosis. It also depends on which part of the lung you are examining. So when the trachea is pulled towards the fibrotic lung, that area alone the tactile vocal fremitus and vocal resonance may be increased, whereas at the lower part, the part which is distant away from the trachea, it may be decreased. So it is variable. So just remember it as variable. Whatever finding you get, you interpret it in the setting of the clinical picture. Now percussion, you are expected to get a dull note. So this corresponds to the anterior part of the, you know that this corresponds to more towards the anterior part of the chest on the right side. So all this location, the percussion note you expect it to be impaired to dull. Okay, so that is a percussion note you will get when you percuss the chest wall. And when you percuss the lateral chest, in this case it is on the right side we should think. So here you may get a percussion note which is dull in the axillary region, that is in the first 4 intercostal spaces you may feel that the percussion note is impaired or dull. The lower 4 intercostal spaces or 5 intercostal spaces, it may be resonant. So in that X-ray what I showed, the axilla is likely to be dull, the infraaxillary region may be resonant. It depends on the extent to which the pleura is also fibrosed. Posterior percussion, we are talking about the upper lobe. So we know that the lower lobe starts somewhere here itself, starts at the D2 vertebra, so somewhere here it starts. So you expect the percussion note to be impaired or dull in the suprascapular region and maybe upper interscapular region. So the most of the interscapular region, the infrascapular region, I expect the percussion note to have the normal resonance. Now regarding the breath sounds, now the same thing what I told as far as vocal resonance is concerned may be applicable here. So in the right upper lobe fibrosis, in this part you may have a bronchial breathing because the trachea is deviated towards the right, you may hear a bronchial breathing. Whereas at the lower part you may have a decrease in the breath sounds, that is possible. Sometimes you may also have a bronchovesicular breath sounds at the lower lobe region because the trachea being deviated there. So in some area it may be also vesicular. So you expect it to be sometimes even vesicular, especially in early fibrosis, but as it builds up you either get a bronchovesicular breath sound or bronchial breath sound. A tubular character is expected, but nowadays we don't differentiate the type of bronchial breathing that much. You can just tell the bronchial character, which I have already told, which can happen. So here the breath sounds can be vesicular, it can be bronchovesicular, or it can be bronchial. The intensity of the sounds are usually decreased in advanced fibrosis, except at the location where it is close to the trachea. It will give a bronchial character at that part alone. So breath sounds I told how it will be. Vocal resonance also I told. And you need not worry about the bronchophony, egophony, whispering, pectrology here. Now regarding the added sounds, crackles are a very characteristic finding you get in lung fibrosis. Okay, you get a coarse crackles in fibrosis, but sometimes the crackles, actually I'll tell the mechanism. There are two mechanisms. You have the airway here, so you have the area which is outside, which is the interstitium. Okay, so sometimes most of the entire parenchyma, most of the times in fibrosis, the mechanism is this fibrotic lung will actually compress the lumen. It will compress the lumen and it will make the lumen little small, and therefore the air which goes through the airway becomes turbulent and will produce crackles. That's the main mechanism of crackles which you get in fibrosis. So that tend to be fine. Okay, that tend to be fine. But when the pooling of secretions occurs inside this kind of an airway, you can get a coarse crackles. So in fibrosis, in early fibrosis, you may get a kind of a fine kind of a thing, but in advanced fibrosis, due to pooling of secretions, you may get a coarse crackles. So already I told you how to differentiate. You need to just make the patient cough and see whether the characteristic of the crackles is remaining the same or it is getting altered. A very good reliable point to differentiate. Then you can tell. And the timing of the crackles can be early inspiratory, it can be mid to late inspiratory also. When the secretions increases in the airway, then it becomes expiratory. So I think here you need not bother much about the timing of the crackles. That completely depends on the severity of the fibrosis and the extent to which the secretions clearance is being impaired and the extent to which the external airway is being dilated. Sometimes in fibrosis, what happens, you have the airway here, and then what will happen, that it's pulled like this, so it dilates like this. So what happens, the lung which is around the airway pulls it outside. It pulls it outside like this. So what happens, this becomes dilated. This is called a traction bronchiectasis, which can occur in fibrosis. So in this case, you may get a very coarse kind of a crackles, which may sometimes have a leathery character. So crackles in fibrosis is very much variable, but remember that crackles is a very important auscultatory finding which you should seek for when you suspect a patient is having a fibrosis. So I think we have touched upon the most important signs of lung fibrosis. So there are a lot of areas where things are a little unclear, it may be present, it may not be present, but these are the overall thing you should remember when you suspect a patient with lung fibrosis. Before telling that the patient has a lung fibrosis, see if these points are there before you tell the diagnosis.